Dr. Sobia Sabir Ali. Ma'am will be talking about obesity. Is it because of my hormones? Please welcome.
Thank you very much, Tahir, for your kind introduction. A very good afternoon and assalamu alaikum, all of you. We are running late, but I requested Tahir if he can kindly give me the time to complete my presentation. I would also like to thank, before I start my presentation, Dr. Umar Raja and Ibrar for giving me this opportunity to be here with you this afternoon. So my topic, as Tahir said, it's very simple, very common, but at times it's very challenging and very difficult to manage. I do not have any disclosures and I do not have any conflict of interest. Lately, it's my kind of like experience that I would like to share with you is that, people are walking into our clinics, regardless of their age group, young, old, even kids are coming over. And the first thing they tell us is that there's something wrong with the hormones. And when we inquire further, the simple, basic response to the query is that they're gaining weight and they're worried that it may be related to their hormone. So for that purpose, I thought I should split my presentation discussing the general facts about obesity, and I'll be just sticking to the Pakistani statistics that we have recently found out. And then I'll be going through, in a rush, as Tahir desires, through the different endocrine disorders. And then while I was putting up this slide deck, I came across with this idea. We have obesity, we have diabetes, so let's get this term PCOS. I'll be coming to that later. So, with regards to obesity, in many societies, including Pakistan, it is considered to be a sign of affluence. It's considered to be something, positive, with more kind of like worldly riches, getting access to good meals. But, then there was this idea that yes, obesity is somehow related to different metabolic condition and it is a possible risk factor. But again, over a course of time, and it's pretty recent, that obesity, it has been fully kind of like considered as a very significant disease, and all the previous things that were kind of considered to be associated with it, they are rather the complication of obesity in short or long term. They can be the cardiovascular, cerebrovascular, diabetes, dyslipidemia, hypertension, gallstone, NAFLD, different kind of musculoskeletal disorders, obstructive sleep apnea, even problems with conception and pregnancy, and then cancers, different cancers, they are associated, and obesity has been well recognized as a cause of premature or early death. And that does not stop with these physical problems. There are a lot of psychological issues, psychiatric problems. A lot of obese patients, they are found to have suicidal thoughts. And depression, again, it's validated to be very closely associated with obesity. Just to go through, how do we classify obesity? So, this table, this chart, it's in front of you, but I need to emphasize and explain it to you that for us as Asian, we have this inherent tendency, or maybe it's our genetics or ethnicity that puts us at a greater risk of developing all the metabolic problems, etc., which I just mentioned. So that is why the world leading authority, WHO, they have relatively put lesser benchmarks for our BMI. And why is that? Because we normally, most of the Asian countries, developing or underdeveloped, we are not, healthy eaters. We do not have balanced diet. We don't have appropriate exercise. Dr. Ali just mentioned that, we have kind of like variable figures for our vitamin D deficiency as well. So because of all those reasons, we may be eating food that may be leading to gain of more adipose tissue. However, we are lacking muscle mass. So for an average Pakistani, he may be having a very normal BMI. But if you measure the waist circumference, if you do the waist-hip ratio, you will get to know what is his situation in terms of his cardiometabolic risk. And again, for Asian people, including Japanese, both IDF and WHO, I've lost the arrows in this, our cutoffs are much lower than the non-Asian population. That is 90 and 80 for men and women respectively. And it's not something difficult to understand that why are we having more and more obesity. You may have seen this animation many times in different presentation. The simple reason is that over a course of time, as we have evolved, we are now taking a lot of more food. That is, our energy consumption is much greater. However, our energy expenditure is not kind of like comparable to what we eat. However, I must raise a point at this point that in some cases it may be some underlying diseases, or it may be our genetics that predispose us to obesity. So please do not discard, do not tell every obese patient coming to your clinic that just eat less and do more exercise. You have to take a detailed history, you have to do a thorough examination, rule out any underlying disorders before you discuss the management plan with the patient. Before 1960s, there were people who were obese, but the trend which is commonly observed since, late 60s or 70s, that the prevalence has been increasing. And I've just mentioned the various causes, environmental causes for that. And in the developed countries, it has been documented that there's a threefold increase. That is, the obesity prevalence has tripled. What about Pakistan? I didn't get hold of the data from 70s, but since 1995, if you compare it to our 2015, our prevalence of obesity has actually doubled, which is alarming because, as a nation, we are becoming more and more comfort-loving. We have more access to heavy calorie-laden food. So perhaps it's about time that we need to do something. There were two recent studies. They were briefly discussed in different talks this morning. One was by Professor Amir from Peshawar, in which, their initial survey was to kind of like look at the prevalence of diabetes. However, during the course of their study, they have also mentioned that most of the Pakistanis, right, they have a much greater. Oh, I cannot find the red dot, but anyways, the red arrows are there for you. So most of these Pakistanis, they come in the category of overweight or obesity. The cutoff over here, I must say, it is for the non-Asian people, but there may be definitely people who are more obese than overweight. And the simple reason for Pakistani overweight or obesity trend is that we have a greater waist circumference or a waist-hip ratio. And this trend for obesity is not just for the pre-diabetics or diabetics. What, the study group they had found was that actually more non-diabetics, they were having more obesity. Similarly, the other study by Professor Basit and his group, they had, categorized obesity according to different provinces. And in that, you can clearly see that Punjab and KPK, they were first. I would disregard 0.5 and 0.2, right? So these two were the top winners, and on the second position was Sindh and Balochistan. And again, very horrendous figures for waist circumference, right? You can appreciate the males, they were way beyond, especially the men from KPK, from their cutoff of 90. And likewise, the Balochi females, or whoever was living in Balochistan, the females over there, they had a much sinister, waist circumference. Further to that, there was a paper published from this survey by Professor Basit. In that, they have simply, kind of projected that generalized obesity in Pakistan, it's 58%. So, 58%, they are having more BMIs. But look at that. 2/3 of Pakistanis, they are having more of central obesity. They are having more abdominal GERD. So are they going to land in CCU, in neurology ward, or somewhere in endocrine department? This is worth a thought. So we had these two surveys, and we know how bad the figures are in Pakistan. So is there some kind of action plan? I didn't spot Dr. Abbas Raza till now, but thanks to him, just recently in May, and obviously, a lot of our colleagues, including Professor Hafizullah, he was a part of this guideline. So on one hand, we just recently found out what is our current prevailing situation in terms of obesity. And on the other hand, now we have a guideline. We have a roadmap of what to do, how do we tackle our metabesity guide. If, or for those of you who haven't seen this guideline, it is available online if you go to the JPMA website. Okay, moving to the next bit of my talk. I mean, there are different endocrine disorders. I mean, you may be seeing them at one point or the other in your practice that are associated. Some of them are very common, like hypothyroidism or menopause or PCOS. The rest are relatively rare, but I mean, they're definitely having some kind of affiliation with obesity. The underlying cause or kind of mechanism, it is different in each of these endocrine disorder, and I'm just going to very briefly talk about those mechanisms. For example, in Cushing disease, the number one problem is that we get more adipose cells made in our body by activation of lipoprotein lipase. And then the second effect of glucocorticoid is that it turns the immature adipose tissue into more mature, more stable, more harder, more resistant to weight loss adipose tissue. And then the third and very kind of like confounding or profound effect of these glucocorticoid is that it tends to distribute the fat in a more centripetal distribution. And it is not just the abdomen, there are a few other areas of the body. For example, I mean, there are buccal fat areas, there's the supraclavicular area, back of the neck or the interscapula, which is very commonly known as the buffalo hump that we encounter in a patient with overt Cushing's disease. And that is not it. During the course of Cushing disease, one of the hormone, that is 11-beta-hydroxysteroid dehydrogenase, it's a long name, that it is also, I mean, kind of like highly expressed, and its role is conversion of the inactive cortisone in the omental adipose tissue to the active cortisol. So the net result of that is we are getting more and more visceral fat within the abdomen in patients with Cushing disease. Historically, Cushing was kind of like considered to have a lemon on stick appearance, as you can appreciate in this diagram. I've just mentioned the different, I mean, fat distribution. Particularly when we come across children with Cushing, we would always desire to treat them adequately at appropriate time, because it's not just the obesity that is a problem in such children with Cushing, but I mean, children, if their treatment is delayed, they would not attain their desired or kind of anticipated adult height. Hypothyroidism, in contrast to Cushing, I mean, in Cushing we see kind of more severe obesity, which does respond to definitive treatment. However, in case of hypothyroidism, there is slightly modest obesity, but I mean, it is still cumbersome for issue. And again, it does indeed confer higher cardiometabolic risk. So what we see in patient with hypothyroidism, that is the underlying mechanism, that overall the BMR is slowed down. There is reduction in the thermogenesis. So there's less oxygen consumption and more energy is there in the body. So where would that energy go? It is stored as adipose tissue. And that is one main reason for getting more kind of like weight issues. And then that is not it. There is fluid retention, particularly the glycoaminoglycans that also stored, and that is why most of these hypothyroid, they get the kind of puffy or a pudgy look, and the classical non-pitting edema that we observe in hypothyroidism, it is because of that. Very easy to explain on this diagram. If you look, so any person with a normal growth hormone, right, he'll be just a normal, ordinary, lean man. Growth hormone, it exerts its effects from skin to muscle to bones and even the fat cell. Contrary to cortisol, it inhibits the enzyme that is lipoprotein lipase, so it discourages fat formation and rather it encourages lipolysis. So a person who loses his growth hormone, he tends to be more flabbier. It's more of an avocado shape, right? Kind of like a puffy face, I mean, flabby arms, and you can appreciate the belly fat as well. However, these kind of drugs, they are very popular in sport industry, right? And many a times we come across that, I mean, the sports person have been using these growth hormone or the other anabolic steroid, which gives them the nice, beefy, athletic Johnny Bravo kind of a look. With, with regards to hypogonadism, I mean, we are coming across this term, that is the adult or the male hypogonadism or andropause. We usually tend to see it in older male, middle-aged men or in the geriatric age group. Basically, these gonadotrophs, their main effect is exerted at the time of puberty. I mean, we have all undergone pubertal spurt. I'm pretty sure I can't see any kid in this room. So, alhamdulillah, all of us had our pubertal spurt. And then, beside its effect on the linear growth and the, kicking off the reproductive system, it is also responsible for giving the typical masculine and the feminine appearance that we, attain at the time of puberty. That is the typical gender-related fat distribution is because of these gonadotrophin. And in terms of fat metabolism, testosterone, again, it inhibits the fat accumulation by, inhibiting the uptake of lipids or TGs in the adipose tissue. So whenever there is gonadotroph deficiency, we again tend to see more adipogenesis, particularly in the abdominal area. And likewise, the risk for the metabolic problem. So whenever there's androgen deficiency, and we replace it adequately, we do see that there is improvement in the lipid profile, in the blood pressure, and even in the insulin resistance, leading to improvement in the glycemic control. One thing while replacing androgens or testosterone, it's very important that, we should not just focus on the total testosterone value, because obesity does cause reduction of the sex hormone binding globulin, which is a reversible trait as the weight is lost. So one has to focus on free cortisol while you are replacing these patients. Menopause or the female hypogonadism, again, we are seeing a variety of trends. These days, we are coming across with females who tend to have their menopause pretty early. So, are we well prepared? Are we kind of encouraging weight loss and, advising them to have a more healthier lifestyle? That remains to be a big challenge. But, as I just discussed about the male hypogonadism, the features are essentially the same, the obesity and leading to the other sequela, with improvement in HRT replacement. But one important point which I would like to address is that menopause, it's really a difficult time for a female, because it's not just gaining a bit of weight, it is also associated with severe autonomic features which can be very, very drastic, can badly affect the quality of life, the physical issues, the mental issues. Likewise, later on they're musculoskeletal, and some women, they do tend to get urogenital problems pretty earlier on. For insulinoma, very straightforward. High insulin, low blood glucose, and the patient has to rush to correct his blood glucose. So it's hypoglycemia leading to hyperphagia. And in most cases of insulinoma, the patient that come to us, sometimes they may be having this, disease for many, many years, and they're really grossly obese. But the good thing is, once they are properly treated after undergoing surgery, their obesity does tend to reverse. In case of insulinoma, I think advising your patient to go on dietary restriction or, kind of having exercise, it would not be a very fair thing for this patient. In fact, I've seen most of these patients, they're very scared to exercise. They kind of limit their mobility because they, get to know that over a course of time, if they're more active, they are more prone to hypoglycemia. Okay, coming to this fancy term, right? I hope you allow me to introduce it to you. I did dig up the literature, but I wasn't able to find anything by the name of PCOS. But if you do find, please do share it with me. So, why am I talking of this new word or this new terminology? Because, I feel is that, PCOS is related to obesity, for sure, right? But is it obesity leading to PCOS or PCOS leading to obesity, which is the egg and the chicken relation, right? So you have to know for sure. And again, in this picture, you have to guide me which one of these two is the PCOS. Sorry, is there a slide not showing? Okay, so I just have 2 minutes more. I'm done, if you allow me. So it's just the final bit. Otherwise, I can stop. I will, not more than 2 minutes. Thank you so much. Okay, so for PCOS, I mean, again, it's a metabolic disorder. There is underlying insulin resistance. And in majority of the women, about 38 to 80% definitely they are overweight or obese. And then, I mean, in 50 to 90% they are insulin resistant. However, please do remember there are lean subtypes of PCOS. So if a lean woman comes to your clinic and she has all the features, please do not disregard, do not ignore her that it cannot be PCOS. And I mean, the very difficult area of PCOS is having adequate weight loss. You may be able to tackle her metabolic problems, you may be able to help her with her reproductive issues, but I mean, there's so much of problem of weight gain, weight loss. She's on a constant seesaw. But I mean, we do see that even weight loss of 5% does help in ovulation. So I mean, those are the things you have to keep on encouraging your patient. Otherwise, I mean, it will be a lost battle. And I mean, again, the reason behind, I mean, this obesity with PCOS is there's these androgens. They are notorious to, I mean, kind of like have our taste perversion. Like most of the people who have high androgen level, they have a greater appetite. They have a profound taste for high fatty diet and a high carb diet, right? And again, that's more calorie. Likewise, insulinemia, it causes reduction of thermogenesis. So again, it's more of energy conservation leading to obesity. And I mean, most of things I've said, so I'll skip the slide. But I mean, if you look at this, I mean, there are quite a list of things that from the early age, they are associated with PCOS. But I personally feel screening every woman who was small for gestational age or large or who's on valproic acid, I think it would be more emotionally traumatizing. It would give patient more of mental distress. And likewise, it may not be very cost effective that if you keep on screening a young woman all through her life to pick up PCOS. The last few slides, I mean, focusing on the weight loss, obviously, is the medical nutrition therapy, more exercise, keto diet, and the low glycemic index diet. They are really becoming very popular in treating PCOS. Bariatric surgery has been tried in a few centers in PCOS ladies who had BMI of more than 35. It had a very good response. Over a course of 1 year, there was 57% weight reduction in those ladies. And likewise, there was reversion of diabetes to normoglycemia. And similarly, the menstrual cycle, they got regularized in 3.5 months' time. Metformin, I mean, it's not just for ovulation induction. Sadaf Farooqi from Cambridge, she holds the view that, I mean, metformin indeed causes 30% of weight over a course of a year or so. But we still await for the time. However, in the trials in which metformin has been used, I mean, it has found to be effective in 5 out of 8 of the time. However, this, I mean, is really augmented when liraglutide is added. So, if you ask which is the most effective drug for causing weight loss, definitely it's liraglutide. Semaglutide, I searched, I could not find, but maybe in future there would be some trials coming up of semaglutide and PCOS. TZDs, right? You can recommend it to a patient only for insulin resistance, otherwise it's no good when you have to consider weight loss. Orlistat, if your patient can be patient enough to bear all the kind of like bowel issues, then perhaps you can try. It's moderately effective. Acarbose, we in Pakistan, I mean, although it's freely available, we don't tend to use it, but it is kind of like effective. SGLT2, yes, we had a very nice, I mean, talk before our tea break. So, I mean, contrary to our findings that SGLT2 are more beneficial for the metabolic and the cardiovascular outcomes, in a small study, again from Oxford, we found out that in contrast to metformin, it is causing more weight loss. However, when it comes to metabolic parameters, it did not kind of do its job, which was kind of like a bit confusing for me. And just the last slide, right? A lot of new drugs, right? Emerging therapies or medications under pipeline, they are being researched. And I'm really looking forward to this new concept of microRNA therapy, right? I mean, maybe there's more future of this therapy, not just for diabetes, obesity, but even PCOS. Thank you very much for your time.